Assalamu alaikum, dear student. It is my privilege to present this lecture today. I am Dr. Mostafa Shalaby, lecturer of colorectal surgery, Mansoura University Main Hospital. This lecture is divided into three parts: introduction, anorectal abscesses, and anorectal fistula. We will start with anatomical landmark. This is an indeed line which divides the anal canal into lower and upper parts of the anal canal. This is the internal anal sphincter, this is the external anal sphincter, and this is the levator ani muscle. This is modified lithotomy position. While performing anorectal surgery, patient will be positioned in this position. This is the left lateral position. During performing digital rectal examination, we will ask the patient to put in left lateral position, and this will be the position of choice while performing certain investigation like colonoscopic examination. This is endoscopy. It is an office-based examination. It allows visualization of the anal canal and lower part of the rectum. This is proctoscopy. It is an office-based examination, allow visualization of more of the rectum. And this is endorectal ultrasound. It is an ultrasound device, allow visualization of the anal sphincter complex and the rectum. This is colonoscopy. It is a lower GIT. Endoscopy, allow visualization of the whole colon up to the ileocecal valve with advantages of taking biopsy. This is the second part of the lecture, anorectal abscesses. What should we know in this part? Causes, classification, clinical presentation, and treatment. These are the etiology of anorectal abscess. The most common cause is non-specific, which is the cryptoglandular theory. This is the internal anal sphincter. This is the external anal sphincter. In between the intersphincteric groove, and in this internal intersphincteric groove, the anal gland located. Infection to this anal gland will cause anorectal abscess or anorectal fistula, and this is what we call cryptoglandular theory. Why it is important to know classification of anorectal abscess, as this classification will affect the presentation and the treatment option. Anorectal abscess may be submucosal, below the mucosa of the anal canal, perianal, surrounding the anal verge, ischoanal and ischoanal fossa, maybe supralevator above the levator muscle, or maybe retrorectal behind the rectum and in front of the sacrum, post-anal behind the anal canal, which may be divided into superficial and deep post-anal. Extension may occur lateral, medial, upward, downward, or even circumferentially. Clinical presentation depend mainly in the exact location, and most of the patient experience intense pulsating anal pain. Sometimes it may be associated with fever or sensation of being ill. This typical presentation mostly seen in case of distal location. What is meant by distal location? Post-anal, perianal, submucosal, intersphincteric, or ischoanal. And if the abscess proximal location, what is meant by proximal location? Supralevator, retrorectal presentation may be vague. And usually the diagnosis depend on history, symptoms, and examination. Further imaging modality indicated in certain cases only, and usually it is indicated in case of retrorectal or supralevator. Treatment. Anorectal abscess is an emergent indication for surgery. Don't wait for fluctuation. Once the diagnosis confirmed, incision and drainage should be performed. Antibiotic prescribed in certain situations in case of extensive infection, immunosuppression, or septic systemic reaction. How we can drain anorectal abscess or perianal abscess? Cruciate incision and excision of the edge of the abscess, and this will allow for proper and accurate drainage. How we can drain supralevator abscess? It's important to drain supralevator abscess from inside the anal canal. If we try to drain this abscess through the skin, this will cause iatrogenic fistula. In case of ischoanal abscess, it should be drained through the skin. What is meant by horseshoe abscess? Horseshoe abscess, it is bilateral ischoanal abscess, and it is important while draining this abscess to make a separate incision for each side. And in certain situations, This abscess will be accompanied by postanal collection, which need a separate incision. Finally, this is the last part of the lecture, anorectal fistula. What is meant by perianal fistula? Causes, clinical presentation, diagnosis, and management. By definition, fistula is an epithelial tract connecting to epithelial surface, and perianal fistula is similar to epithelial surface, perianal skin, and the other epithelial surface is the mucosa of the anal canal or the rectum. And in this picture, we are able to see a metal probe passing through the external opening on the perianal skin through the tract, which passing through the sphincter muscle, anal sphincteric muscle, and coming from the internal opening in the anal canal. Causes similar to causes of anorectal abscesses, with the most common cause are cryptoglandular theory. And it is also important to know the classification of perianal fistula, and this classification will affect the decision-making treatment options. Perianal fistula may be classified into intersphincteric fistula, passing through the internal anal sphincter only, transsphincteric fistula, passing through external and internal sphincter, and transsphincteric may be subdivided into low transsphincteric, taking less than 50% of the sphincter complex, high transsphincteric, taking more than 50% of the sphincter complex. Suprasphincteric, arching high and passing through the external anal sphincter, then passing through the lower part of the internal anal sphincter. Extrasphincteric, arching high and passing through the external and internal anal sphincter. And if we notice this classification based on the amount of the sphincter complex included by the fistulous tract. Clinical presentation. It is a chronic condition in which patient will complain of discomfort, may be associated with secretion, which can cause anal eczema. By examination, we could inspect external opening, and in case of this external opening closed by granulation tissue, this does not mean that the fistula healed. No. Digital rectal examination allows us to feel the internal opening, which is something difficult, and usually it is located as the dentate line. In certain situations with low-lying fistula, we could palpate the fistula tract as a string-like structure. What is meant by Goodell's rule for anal fistula, and what is the important? Goodell's rule, it is a rule imagining there is a transverse line, this transverse line passing in the through the center of the anus, and fistula anterior to this line will go straight, and fistula behind and posterior to this line will be curved. What is the important? It allows just an expectation of the fistula tract during surgery. And to remember this dog. Anterior it will be straight, posterior it will be curved. Diagnosis. There is what called fistulography. Fistulography means cannulation of the external opening, inserting a dye through the external opening to pass through the fistula tract and coming from the internal opening inside the anal canal or the rectum. And actually, fistulography is something obsolete. There is no additional information can give. And this is endorectal ultrasound. Endorectal ultrasound allows visualization of the sphincter complex, visualization of the fistula tract passing through the sphincter, the amount of the sphincter included, localization of the internal opening, and if there is any associated abscess cavity. And this is MRI fistulography. It can give the same information gathered from endorectal ultrasound. What is the goal of surgical treatment of anal fistula? Elimination of infection, closure of the fistula tract, preservation of the patient fecal continence and sphincter function, minimizing the recurrence. It is important to remember that This fistula passing through the anal sphincter, and cutting the anal sphincter can affect the fecal continence mechanism. Continence mechanism depend mainly on the external anal sphincter function. So as much as we can, we should preserve this function. This is an algorithm for treatment of a perianal fistula. Initial assessment including history, physical examination, endoscopy, and colonoscopy. When to perform colonoscopy if we are suspecting this fistula is secondary to inflammatory bowel disease or malignancy. Secondary assessment including endorectal ultrasound, MRI fistulogram. When to perform endorectal ultrasound or MRI fistulogram in complex fistula. What is meant by complex fistula? Recurrent perianal fistula after surgery, fistula secondary to inflammatory bowel disease, anterior fistula in female patient. Why anterior fistula in female patient is something important, as female patient has thickness of anal sphincter less than male, and especially female patient in a childbearing period liable to trauma during vaginal delivery to the anal sphincter. What is meant by complex fistula also? High transsphincteric fistula, including more than 50% of the anal sphincter, and extrasphincteric and suprasphincteric anal fistula. How we can manage simple fistula? By lay open. How we can manage complex fistula? Lay open plus sphincter reconstruction, lay open plus seton or advancement flap. Principle of any surgery for anal fistula are examination under anesthesia while putting the patient in modified lysotomy position, and after giving the anesthesia to the patient, spinal or general anesthesia, we should perform careful endoscopic examination to confirm the diagnosis and exclude any associated pathology. The next step to identify external and internal openings. It is a critical point, and this will be by examination. If it is difficult to locate the internal opening, we can insert a catheter or cannula through the external opening and inject a dye, methylene blue or hydrogen peroxide, to allow it to come from the internal opening and be able to see this internal opening in the anal canal or the rectum. In certain situations, we can insert a probe through the external opening, passing through the fistula tract, coming from the internal opening. And the final decision of the treatment will depend on the amount of sphincter involved in the fistula tract. This picture showing a metal probe coming from external opening, passing through the fistula tract, and finally coming from the internal opening. This picture showing lay open technique. What is meant by lay open? We will open all the layer of the fistula tract, and in certain situation, if we cutting through a big amount or large amount of the external sphincter, this will be followed by sphincter reconstruction by vicryl. Lay open plus seton. What is the importance of seton, or what's meant by seton? Seton, it is a thread of non-absorbable material. This material will be proceeded through the external opening, coming from the internal opening, after passing through the fistula tract. And we have two types of seton, cutting seton and drainage seton. Cutting seton allow gradual cutting through the external sphincter. If the fistula including a big amount of sphincter and we are afraid to cut this through this part of the external anal sphincter, as this may causing fecal incontinence, we will cut through the internal anal sphincter, doing coring of the external anal opening and subcutaneous tissue, and we will leave this seton surrounding the external anal sphincter. This seton allows gradual cutting. What is the importance of gradual cutting? This gradual cutting will followed by subsequent scar formation, and this scar formation will preserve the function of the external anal sphincter, which will preserve the continence mechanism. And this is drainage seton. In certain situation, for example, in patient with Crohn's disease, patient after radiation therapy, we can put draining seton. This draining seton allow drainage, and usually it is in complex situation like Crohn's disease. This is what meant by advancement lab. If we are able to see here, we will bring a part of the mucosa, submucosa of the anal canal to cover the internal opening. And this a trial to preserve the external anal sphincter to preserve the continence mechanism. We still have new technology. This technology aiming to preserve more and more of the sphincter, preserving the continence mechanism. Just we should know the name of this procedure, fistula laser closure using a laser caster introduced through the fistulous tract, causing denaturation and closure of this tract from inside. Another technology is video-assisted anal fistula treatment using fistuloscope, something similar to the laparoscopic device we use in laparoscopic cholecystectomy, but this laparoscope is designed for this type of surgery, and this allow cautery and coagulation of the tract from inside. This is a ligation of intersphincteric fistula tract, and this allow ligation of the fistula tract in the intersphincteric groove. And as we know, stem cell become a part of the future and daily practice. We can inject stem cell surrounding the fistula tract and inside the fistula tract, and this allow healing of the fistula with preservation of the continence mechanism. Thank you and good luck. If you have any question, you can send me this question on my official email, mustafashalaby@mons.edu.eg.